So we've actually got some ample time now for questioning. Has anyone got a question for Alison, our first presenter? Well, Alison, I've got a couple. I just think it was a massive task for you to do the task analysis of actually breaking that down and even to get it down to 35 competencies. Can you talk a little bit about the workflow? So when those competencies sort of came together, did that actually help with workflow in the workplace, I guess, on the student placement, when you allocated the tasks out?
So once the students had actually completed their training, did it improve the workflow? One thing I want to say that I missed in my presentation that's really critical to this is that both professional skill sharing and this experimental investigation of student skill sharing is very much around non-complex cases. So, you know, I just thought people might be squirming in the audience when I said that OTs did functional mobility assessments. It was on, you know, your sort of elder population who have just general functional decline and no other comorbidities particularly. So, in terms of helping the workflow, no, not really, because what we had was we had physios who were on a 5-week placement and OTs who were on a 7-week placement. And we were actually flat strap getting, we had all the competencies ready and all the training booked into a timetable, ready for when they started. But the process of training for the Calderdale framework is quite rigorous. You have to do classroom teaching that includes underpinning theory, a very comprehensive clinical task instruction, and then you have to model the clinical task to the students and get them to model it on peers. And then the student has to observe a clinician doing the task with a patient, either on one occasion or more than one, and we use teaching on the run principles. So that's a 4-stage process. And then the students actually have to do the task under observation and either get signed off or get learning development requirements identified for them to then be reassessed. So actually what we found was that in a couple of the clinical tasks they were competent and they were able to use them a few times in the clinical placement, but the more complicated ones like functional mobility assessment, where they had 5 or 6 different pieces of mobility equipment that they then assessed the patients with, they only just got signed off by the end of that 5 or 7-week placement, so there really wasn't time for them to consolidate that skill or to have any impact on workflow. So I think the progression of this is that we're now looking at amalgamating our community-based rehab services and perhaps, you know, having some training, you know, get them familiar with the competencies before they come on placement, but focus on 4th-year students perhaps that are on longer placements.
That really does make sense, and I think even from a staffing perspective we have issues with making our staff competent, let alone students in such a short time frame. So that's a big challenge. Thanks for that.
I think the other big challenge, sorry, is throughout we didn't recruit to the project till March, or we didn't get funds released, and you know there was a delay in getting staff in. So we were actually quite a few months gone by the wayside by the time we were on full bore with it. And the actual teams were having to do it from scratch, so the teams didn't have it embedded as business as usual by the time the students were in place. So I think now that this team are doing that, you know, by next year, then it'll be a lot more embedded and it'll be a lot slicker process.
Thanks, Alison. And do you think that there will be more interest next year from the students themselves, that word's out about the program?
I think that we're just on with analysing the focus group at the moment. The students found it a very valuable experience. We also got them to teach one another the clinical tasks. So the physios taught the OTs the clinical tasks and vice versa. I think it was quite a challenging placement for them. Yeah, so there were a lot of very positive comments. They did enjoy learning the clinical tasks, so hopefully so.
Are there any other questions? Yes.
Hi, Ros Harrington. I'm just wondering, so you identified a lot of generic tasks. Do you think that the OT and physio have lots of similar elements in their training. Do you think that it would be generic to other practitioners outside of those disciplines, so nursing, for example, and to implement this program?
So, sorry, which generic task were you mentioning? Things like the carer strain index?
So you've differentiated your tasks out into different things that can be taught by an undergraduate student regardless of their discipline. What I'm asking is, do you think that there are boundaries around what disciplines could be taught those tasks?
Great, thank you. I've been doing Calderdale framework for quite a few years now, since around about 2008. And I've used it in nursing teams and therapy teams. My experience has been that as soon as you try to cross the psychosocial physical boundary, it gets really messy, or tricky, should I say. So OTs can work with psychologists and social workers a bit more easily perhaps than for example, dietitians or physios, because they do an element of mental health and physical training. But yeah, certainly psychosocial, we did psychosocial screening, and that has been a really, really tricky task to get some professions to learn and be comfortable with. It's an easier hit to do it between OT and physio because, like you say, there are synergies between their training and the sort of baseline anatomy physiology knowledge at a very basic level is similar. And so there's more crossover in those professions. So we tend to use those two professions really to start the process. But we found a lot of value. For example, the OTs and physios are using the subjective global assessment and high protein, high energy dietary advice, and they use that a lot in their clinical work and find that invaluable. And the dietitian then, finds it quite useful if somebody's already gone through high protein, high energy dietary advice with a patient, so that once the patient comes to them, they've had a chance to try it and have all of the, the right kind of questions to ask them. We're also looking at, within the clinical teams, not in student placements, social workers actually learning to reinforce correct mobility patterns and assess for grab rails, potentially. So we are starting to explore that territory, but it's a lot more difficult.
Thanks, Alison. Are there any other questions for Alison? No? Does anyone have any questions for Suzette and Helen? I've got one. Surprised. You had up on one of your last slides about emotional resiliency required. Do you want to just expand on that?
In looking at the literature prior to in developing it up, one of the key things that came out that was really necessary for success of a rotational placement I guess I call it emotional resiliency, but it's the ability to be able to cope with the complexity and the intensified learning that happens, similar to what you were saying, within 5 weeks or 4 weeks. There's a lot to take on board. And so that requires an ability to be able to manage that complexity, as well as being able to hold their own anxiety around starting a new placement and what that means in establishing all those networks, then to leave it in, say, 4 or 5 weeks and start somewhere afresh. That requires a certain amount of emotional resiliency. And certainly what we discovered was that was really borne out in our placement. And we had 6, we finished with 4. 2 did not continue through for a couple of reasons, but predominantly that was probably the main reason in being able to cope with that. So it was that the setting was not a good match for the student, and so but those that came through the other end were just brilliant and flying. For me, it really seemed kind of almost polarised to a certain extent, students' ability to cope in a really dynamic, changing, fast-paced kind of environment, even within aged care. In the hospital context, it's still acute, even in in the longer term placements, there's a real push for moving people out of acute beds into the geriatric assessment units and moving that out. So there's push, push, push all the time as part of that flow through was certainly a real emphasis. So there's always a sense of pace with that. And so the students that actually finished with that were just really, their confidence and their identity and all those things were really, really strong. So it wasn't about the placement per se, it was about the match between the student's capacity to manage that in that environment, and emotional resiliency, I think, kind of covers that.
Helen, from your end then, is there a way that you can select the students? It's like a million-dollar question, isn't it?
I think, I suppose one of the things for us in terms of innovation, I mean, clinical rotational models aren't new. They've been around for a long time, and they've been obviously in a number of other disciplines. The social work, the major challenge is that we have been very much on a one-on-one apprenticeship model for many, many years. So there is a large emphasis, because of the length of placement, on building a relationship with the supervisor. And I think that was sort of one of the things that the clinical rotational model showed us was that, in fact, it wasn't just reliant on that. So when a student was struggling, you had a number of different people putting in input. Equally, you could, I think it enabled Suzette to be more proactive and to actually act earlier in the student's best interest to say, look, we don't think that this is actually going to work out. So that was one thing. In terms of selection of students, I don't think it's for every student. I think some students we did find with one of the students who was just, as we said, that emotional resiliency, but also that quickness to learn. You really do have to be able to be on your feet and be able to think on your feet. So if you have somebody that just needs that little bit more time, that little bit more processing, that slower pace, I wouldn't necessarily say a clinical rotational model in a major tertiary hospital in Brisbane is the ideal placement for you. So we're going to, one of the things we want to do is we want to go back to the universities with the model, if it can, hopefully when it continues next year, and be able to look at that in terms of selection of students.
If I could just say one thing to that, what we actually found was that there was one student amongst the 4 who finished who was international student, English as second language, and what it showed me was that the model could cope with one student perhaps that needed a little bit of extra care. We adapted the rotations. The student didn't do all the rotations. He stayed in areas longer. He just finished yesterday and was just thrilled with what that experience was for him. So I thought the model can cope perhaps with one student who needs extra care around that and some adaptation, but on the whole, you can't have half the students struggling.
I actually think that one of the things that we've looked at in terms of where to go through from here, which is probably very much like the US models, is to actually not have the rotation completely within the hospital setting, actually have a rotation that goes from another agency, a community agency, in an aged care facility or whatever, and then rotate. So you only have a placement in the hospital of, say, 5 or 6 weeks, and then you rotate out into other areas. That would actually probably be more suited to a wider, diverse population of students. And when you consider that we are getting a number of international students through an English proficiency as one of the key sort of requirements, putting them into, again, a major tertiary hospital and expecting quite a high level of English proficiency to be able to write notes and stuff, it does create a huge challenge.
Look, I was just wondering about the move from, you said, from a one-on-one supervision model to a team supervision model. And I'm wondering to what extent, if at all, you had to manage that. And if so, what did you have to manage?
It was part of the design to support the changing clinical environment as a way of providing support for field educators. So even though they had the responsibility, the initial field educator relationship, providing one-on-one, I thought if they could provide that fortnightly, and on the alternate week, the students are in small groups. So we had 6 students, we included the other 2 students that we had on placement. So 8 students, Helen took 4, I took 4, to provide the small group supervision. And what was actually fueling that again was what I had discovered in the literature around what students, the value they say of a variety of supervisory experiences. So I wanted for the students the continuity of that initial relationship, but also wanted to provide some reprieve for that, and also to expose students to kind of a neutral person as they proceeded through the rotations. But the main thing that's coming out in the student interviews is the enjoyment and the benefit of the peer. They experience that as peer supervision within that, and that is also borne out in the literature. So it was shaped by the literature. So it was originally part of the design that so in the structure of what the students would be experiencing, the timetable on the Monday afternoons virtually was either a tutorial which I ran, crack workshops which Helen basically was responsible for, but we did together, or on the fortnight there was the group supervision, and they broke into two different groups. So basically I set it up and organised it, but it wasn't difficult at all because they were in the one geographic location, but they certainly, in terms of what they found beneficial, it was the one-on-one relationship and then the experience of that in the small groups.
And I think we had to, there was certainly a lot more management, there's certainly a lot more impost on the clinical educator role and Suzette's role, but in the long term we were trying to shift the culture within a department where a lot of the times with that apprenticeship model it's based on the individual practitioner. If the individual practitioner says, look, I'm fed up, I don't want to take a student, too bad, too sad. So in terms of building capacity, we knew we had to shift it from the individual practitioner into a team-based environment to say, it's fine for the Queensland Health to say it's everybody's core business to take students, but you've actually got individual practitioners that have to be able to take that on board. And in a challenging clinical environment that we had where we were losing staff, in that department we lost 12 staff in 6 months due to cuts. So, we really, Suzette put there was a lot of impost in trying to keep that and that motivation going and sharing that load around so that the students actually became an asset to the teams as opposed to an impost on the teams. Was a major shift, we thought.
Hi there, Tegan Carrison, UQ Healthcare. So my question to you is, because you are operating in such a large tertiary environment, the RBWH, I was really interested in how the other departments and units responded to this change in model. So you've gone from that apprenticeship model to this rotation model. So how did they respond to that?
Interesting. It hasn't actually impacted them at this stage. Talks, early stages of what that looks like in terms of the clinical educator network. In our department, social work and psychology have combined to the one unit. At this point in time, that's probably more something for next year. The clinical educator in psychology is on maternity leave, so once she gets back, we'll have discussions around what that looks like. But as yet, it hasn't been a multidisciplinary model. We're keen to see what that looks like, and my thinking would be OTs would probably fit in well with what we're doing, but we haven't gone down that path as yet. But certainly keen to explore that.
Thanks, Suzette. Any other questions? Not coming from an allied health background, but a nursing background, it's a bit of a relief, really. To hear that you have very similar challenges than what we do in nursing, and I can see some placement people in the audience here that, they're very similar challenges, certainly with that capacity for staff to take students and make it part of their core business. Thanks for that. Does anyone have any questions? Oh, we've got one over here.
Hi, Paul Wilkinson. My question is really at the other end. So my role is in actually accreditation of university courses, and I'm wondering what kind of dialogue you may have had with your respective accrediting organisations or bodies around some of these innovation in placement programs, and whether you've been supported in that or had any sort of guidance around, perhaps changing the way in which we've worked in the past and still ensuring that we meet the competencies that our professionals need to meet. Any of you? I mean, it was an open question. I'm just aware that a lot of you are at the sort of clinical educator practitioner end and not the academic end, so I'm not sure whether you can answer that.
Probably one of the key things that I found was that and others had mentioned it, was the different universities' assessment criteria. And so when I've got a number of students from different universities trying to understand all the different assessment, and I thought to assist the rotation, it would be really useful to try and pull all that assessment together, seeing at the end, for social work, it all has to conform to the ASW practice standards in what I called a tracking document. I actually didn't call it a tracking document initially, which kind of didn't fly too well. So we called it a tracking document. I'm yet to find out how well that facilitated the process, but I know a couple of the universities were really, because it was the new practice standards which have only come out fairly recently, were really very endorsing of that work. Some other response not so strong. So certainly we were engaging and having those discussions. For me, those discussions were with the field educators who are on the other, from the university, who are on the other side of that assessment. But in terms of the actual curriculum, Helen might like to talk to that.
We did have some discussions with our academic colleagues because, again, as I said, there were variances across the three institutions that we worked with as to whether they taught health as a unit, whether they taught around ageing. And at the moment there is nothing in for social work around a particular curriculum on ageing. There's curriculum being developed on Indigenous issues, there's curriculum for mental health, there's a number of different curriculums, and I suppose our accreditation bodies must get to a point where they think, well, how much more can we try and put into a program? I always thought, but this is my idea alone, I always thought that you could actually develop what you'd call an adjunct curriculum. So where it might be something that the students sit on, and it might be a pre-placement sort of thing that they could do. It's not mapped into an assessment, but it actually helps them to pre-prepare for a placement. There could be some ideas around that universities might be interested in terms of that. So, because again, what's the motivation for the students? Because that was the issue we had about their participation in the curriculum. What was their motivation? Their motivation was, I need to be able to do this, to be able to come up to speed so I can actually work effectively and succeed in placement. That was their motivation, so we worked off that. But we didn't have any formalised assessment in that process. So, but I think there is capacity to be able to develop those sorts of modules. I wouldn't sit them in a Queensland health environment in terms of, but that's just my opinion, because I think you've already got the student interfaces at universities, and that's where students can easily access that. Trying to get students to access stuff in Queensland health, I've always found has been historically problematic, but that's just me.
Thanks, Hel.
If I could just make a comment, in terms of the interprofessional education model and the emphasis on engaging with that, which was our whole remit, one of the challenges for us, I suppose, was that different disciplines clearly have got their assessment criteria, and then even if you were of the same discipline, different universities would have a different, potentially a different criteria again. So dare I say that at the moment, even though there seems to be a lot of encouragement around educating students in an IPE framework, the assessment doesn't necessarily allow for that. So for example, psychology students, I'm just going to pluck one, some psychology students require 1 hour supervision for every 8 hours on placement. That supervision needs to be done by a clinical psychologist, but where they're getting supervised by a number of other team members, it would be useful if there could be some give and take in terms of that supervision, such that there could be a percentage of the supervision which could be from another practitioner. I mean, that's maybe not, that sounds very simple, I know, but I think that that sort of discussion would be very useful if we truly do want to embrace an IPE delivery environment, or service delivery environment, of which students are part of actually delivering the services. And I could just say, while I'm talking around that we've found that the clients that are being referred to our programs for that student-assisted model are actually very complex. So, and that's something that we couldn't necessarily have anticipated altogether up front. So that's actually, produced another layer of needing to develop those competencies. One of the things in our IPE assessment is that it does have the psychosocial and physical components. and that's been very interesting. And early on, I'm looking at Tegan and Daryl, but early on, some clinicians were sort of like, well, we can do all of this, but you know, that's, one of the groups said, well, we can't do some of the physical side of it, like the sit, stand and the 6-minute walk. But we've actually started to work with everyone, and we've got around those things. But you definitely need to take that on board. Yeah.
Thanks, Frances. Has anyone got another question? Donna.
Hi, Donna Bonney from the MARTA and the SQRTN, and we're also very interested in IPE because we're a health service, and actually that leads to interprofessional practice, which leads to better patient outcomes. But this year I've been to a few undergraduate showcases of IPE, and there's been a distinct lack of medical students, N equals 1, from a medical school of 1,500. So I'm just interested, particularly in the GP superclinic, how you've I couldn't quite see from the data whether you've had medical student engagement there, and if you have, how did you get it? And if you haven't, how do you plan to get it?
So at the moment we have medical students on placement in the GP superclinic, and that's a very traditional model with the general practitioners. In this first 6 months of actually running with the student-assisted model, we haven't had medical students come involved in the program delivery of the programs I presented today. But there's a twofold plan. I suppose one is with the medical specialists that are coming on board. So one example of that is the continence clinic. So Lucy Dakin is a geriatrician, and she's going to have, not undergraduate, but she'll have actually advanced trainees being trained in the continence clinic. So that then introduces us to a second tier of being able to, with the advanced trainees, have medical students working with them. And part of that clinic is a specialist continence nurse and a specialist physiotherapist. So then they would be part of that medical students, or medical nursing and others, working within an IPE continence clinic, if that's so. We've got plans in that regard. In terms of the other programs, it is an ongoing discussion with people like Jeff Mitchell at the School of Medicine at Ipswich campus about how to release the medical students from their usual placement obligations, I suppose you might say, to enable them to participate. So there's a lot of scope for the medical students to participate, and there's a couple of ways, but one of them would be for them to participate in the IPE assessment process with a student from a different discipline, and the other would be what happens with some of the group programs, some of which have got an education emphasis, some of which have got an exercise emphasis, even though the EP or in the future the physio student might be the primary discipline, if you like, the psychology students, the dietetic students still have a dialogue with those clients in that environment. So there's scope for the medical student to do that. I think that what we need to do is work with medicine to frame up what the student's role looks like in those program environment.
Thanks, Frances. Anyone got any other questions? Frances, my question to you is any tips on the scheduling? Because obviously your programs are dependent on having student involvement.
I think that the big tip is we were lucky enough to be able to, we weren't fitting the students into necessarily an existing model, but we were able to develop the model to fit the students. Having said that, though, we were very aware that at any one time we may or may not get placements from a particular university or from a particular discipline. So early on we took the decision that we couldn't make the programs, even though they're dependent on the students in terms of the delivery, we couldn't make them dependent on a particular students from particular disciplines at any one time. Now, that's a pretty big statement, given that there's the scope of practice, all the types of things that we want to deliver. But for example, the initial assessment process needed to be able to be done by whether you were an EP and a dietetic student together, or whether you're an OT and a speech student sitting together, and any combination of those things. So the initial assessment was a core component. And then what we determined was then if there was need for some more specific individual assessment, if we didn't have an OT student on placement at that time, then they might, that part of their assessment might have to wait, but instead we'd identify, well, what were other priorities for this client, and we would stream them into those areas where they could get some individual assessment. Does that help? So I suppose we really had to make a decision that we weren't going to stop the delivery because this semester we couldn't get an OT student. We were going to continue to deliver the programs kind of regardless, but clearly within that we needed to have to not put people at risk because of that, and be able to refer back to other people if that was the case. But the programs, I suppose, are just that. They're also rolling programs, so it enabled us to pick up with the clients at different points along a continuum, as opposed to you have to get this right now, but if we didn't have someone to deliver that at that point in time. Does that?
Yeah, that does answer that question. I guess it's amazing, though, that you could have a vacancy. You know, for those of us that are on the training networks too, it's a student vacancy or unable to get a particular discipline on the program.
I suppose early on that was, I think, about us ensuring to the university sector that we had the competent and good clinical supervision staff in place who understood the requirements for the student learning. And once we had got those relationships well established, and the university staff have been fantastic on our working groups, but also the hospital and health service alliances have been very important to that, because we've been able to sort of, I guess, allow them to see us, you know, working and what our commitment is to a high quality placement. So that was part of that, yeah.
I think with a lot of these projects too, the fact that it is innovation and these new ideas that are coming out, I think it's only a matter of time before they're sort of picked up as and being run with as solutions to a clinical training placement problem. Are there any further questions? I'd just like you to all put your hands together and thank our presenters. It's been a fabulous session, and once again, it's a relief that we're all struggling in the same areas. And I think we're going to head out to lunch. Thank you.